Hi, good evening, friends. Yesterday, actually, I was quite busy and I could not even schedule the lecture and could not even inform people in time. I'm sorry for that. Today, I'm back with a topic which has become a very hot, controversial topic. In fact, this afternoon, I debated on this topic. I was against the motion. That is, I spoke for no removal of ovaries. Uh, and it was quite an exciting debate. Many people missed this debate, so they requested me that, can we have the lecture on the same debate that you had? So I quickly scheduled that, and I'm sharing this lecture with all of you who could not join the debate in the afternoon at 2 o'clock. So here it is for you. To remove or not to remove ovaries at hysterectomy for benign conditions. A lot of people have confusion regarding the removal of ovaries. There are so many terminologies, elective removal or prophylactic removal. So all these things I'm going to clarify with evidence. What does the evidence say? So as a prelude or as a tone setter of the topic, I would like to invoke Hippocrates, who said, primum non nocere. That means first do no harm. Whatever you do, you must always follow this principle in medicine. That is, first do no harm. So in that direction, I'll be talking, and you already know what is on my mind. I said a lot of people are confused regarding the terminologies. That's why the debate goes haywire. Elective salpingo-oophorectomy means removal of both tubes and ovaries in a patient who has no known indication for the procedure. That means there is no ovarian pathology or there is no hereditary ovarian cancer syndrome, nothing. Simply because you are removing the uterus, you will offer the patient like buy one, free one. Anyway, I'm opening the abdomen. Let us remove the tube and ovaries also. On top of that, you tell the patient that, future there may be problem in the ovary. So you may need one more surgery. So patient falls for that. The second one is risk reducing salpingo-oophorectomy. Now here, as you can see here, the word is risk reducing. It makes a little bit, advocacy for removal of the ovaries. Removal in a patient with a hereditary ovarian cancer syndrome. Obviously, nobody is going to object for this because, in fact, you have to advocate this if there is a family history or hereditary risk for developing ovarian cancer. It definitely makes sense to remove the ovaries along with removal of uterus for other benign conditions. Risk reducing salpingectomy. Now, in fact, this is to be done as a rule in every single case. There is absolutely no controversy in removal of the tubes. There is no point in retaining the tubes there. In fact, according to the stick theory, the origin of ovarian cancer is from the cirrhosis of the tubes. So removal of just the fallopian tubes in a patient with a general population risk, it is not hereditary risk, general population of ovarian cancer syndrome. So in other words, it's a general population. As I said, for 100% of the patients, when you're removing the uterus, please don't leave behind the tubes. You have to remove the tubes. But ovaries, I will tell you when to remove and when not to remove. Prophylactic salpingo-oophorectomy has been used inconsistently. That's what I told you. There's a lot of confusion regarding this terminology. Now, instead of saying elective salpingo-oophorectomy, they say prophylactic salpingo-oophorectomy and confuse the people. Actually, what do they mean by prophylactic salpingo-oophorectomy? It is risk-reducing salpingo-oophorectomy, isn't it? Prophylaxis against developing a cancer. Who develops the cancer? It is anybody can develop cancer. That's another question. But hereditarily, genetic risk is more important in deciding this topic. rather than just go by the general population. You may develop a risk. That way, if I walk on the road, there is a chance that I may meet with a road traffic accident and die. That risk is there for every single person, for every single travel on the road. That doesn't mean that we should stop going onto the road. I hope I'm clear. It has been used variously to refer to salpingo-oophorectomy for the prevention of ovarian cancer. See, that's what I said. Prophylaxis means prevention of ovarian cancer in either patients at average risk or those with a hereditary ovarian cancer syndrome. So when you say average risk, again, you are not very justified in removing the ovaries. But again, you are using the same terminology as prophylactic salpingo-oophorectomy. That's where the confusion starts. So I hope I am clear that when you say elective salpingo-oophorectomy, there's absolutely no risk. The risk is general population risk, and you're simply removing the ovaries. That should not be done. That's what I'm trying to say. Whereas risk reduction is a specific risk because of genetic factors, there definitely ovaries have to be removed. Tubes have to be removed irrespective of the hereditary risk or general risk. Tubes need not be spared at all. There's no point in sparing the tubes. You have to remove the tubes because it's the new theory of stick theory, tubal origin of ovarian cancers. Now, what are the surgical effects of any surgery that you do, that is especially the removal of the uterus and removal of the ovaries on ovarian function? There is something called surgical menopause following bilateral oophorectomy, or RO means retained ovarian removal or leftover ovarian removal. It results in an abrupt drop in estrogen levels. Abrupt drop. Anything that abruptly happens is like a shock, isn't it? There is always a slow transitional thing that happens in the body. Women move slowly into menopause, so it won't be so shocking or so dramatic. Most of them don't even get post-menopausal syndrome because they slowly go into that. So there is an abrupt rise in FSH level because of the drop in estrogen level and complete cessation of production of androgens, estradiol, and progesterone. As a result, there will be abrupt onset of symptoms of menopause, which will be very, very distressing, more distressing than the natural menopause that happens over a period of time, slowly. Patient has the time to get adjusted to the lower levels of estrogen. But here, there's absolutely no time to get adjusted. Abrupt. Intact postmenopausal ovaries. This is more interesting and more important to understand. Even if the lady has attained menopause, if you have left behind the ovaries, there is continuation of the hormonal secretion. So postmenopausal ovaries continue to be hormonally active for many years beyond menopause. So this becomes a very, very important issue or a very, very important advocacy point to retain the ovaries. Producing androgens, that is testosterone, androstenedione, and DHEA, as well as very small amounts of estradiol and estrone. So even a postmenopausal ovary secretes estrogen. So why do you remove that? When the lady can have the advantage of the natural estrogen. All of us know if you give synthetic estrogen from outside, it has got its own problems. So that is the reason. In fact, why I wanted to take this talk today was it can be a question in the recent advances for you. And there will be a debate, that kind of a question nowadays in the question paper, and you have to write all these points on evidence-based. Estrogen secretion by the postmenopausal ovary, of course, eventually ceases, but it will take its own long time. Ovarian secretion of small amounts of testosterone and DHEA may continue into the 8th decade of life. Even at the age of 80, there can be secretion of androgens. You may say it is androgen, it is not estrogen, but you know, these androgens are converted in the periphery into estrogen. So that way, at least they will get some benefit out of it. Indications for oophorectomy. Of course, as I said, there are definite indications for oophorectomy. And because some patients with extra ovarian pathology may also benefit from oophorectomy when you do a hysterectomy for other reasons. What are they? Endometriosis, for example. You are doing, let's say, endometriotic surgery in an elderly lady who has completed the family. Then it makes sense to do TH-BSO instead of just doing TH, because if you retain the ovaries, then the endometriosis may not, go away. Similarly, tubo-ovarian abscess. What is the point in keeping that ovary which is already been infected and destroyed? Pelvic adhesions and pelvic pain. Sometimes, if the ovaries is deeply in the adhesions, you will not be able to retain that ovary. You may have to remove en masse. That's okay. So I said evidence-based talk I'm going to give. What are the studies I am basing my talk on? These studies regarding elective oophorectomy are the highest quality data on long-term health outcomes. Nurses Health Study. Look at the numbers, 29,380. Women Health Initiative Study, 25,448. A retrospective study of data from UK National Database, 113,000 patients plus patients. And Mayo Clinic cohort study, 2,365 patients. These are very high quality data, and that's why we may have to take them. Both NHS and Mayo Clinic cohort study had long-term follow-up periods of 28 to 30 years. See, it's not just the number of women they have included, they have followed these women for 28 to 30 years. So isn't it highly reliable study? Adequate to assess outcomes that are more common for patients over the age of 60 years. So what are the risk factors they have looked for in this 28 to 30 year follow-up? CVD and stroke risk, chronic kidney disease, dementia, osteoporosis, breast and ovarian cancer, and all-cause mortality. So what are the risks of elective oophorectomy? Again, let me clarify. Elective oophorectomy means you are simply removing ovaries without the lady having any risk other than the general risk for ovarian cancer. I will talk about the general risk of ovarian cancer, then you will understand why I'm saying so. General risk is very, very negligible, like any other risk. It's something like, when you go on the road, I'm repeating myself, but if you go on the road, there's a chance that you can die. Okay, so that kind of a risk. Added surgical risk. For hysterectomy via laparotomy or laparoscopy, BSO does not appreciably increase the complexity of the procedure. Of course, when everything is fine, the surgery that is just putting 2 more clamps is not going to harm any which way. But when the BSO is combined with vaginal hysterectomy, the procedure is potentially more difficult. It's not easy to remove the ovaries from below. Only 20 to 30% of the time they say you can easily remove it. Otherwise, you have to go beyond the infundibulary ligaments from below. Sometimes you slip the ligaments. It's very difficult. And complications increase if adhesions or other intra-abdominal pathology are present, whether you do it abdominally, laparoscopically, or vaginally. So there is a risk. It's not that, buy one, free one, everything will be fine. Long-term health risks. Accumulating evidence, you look at the number of articles that I'm quoting, 1, 2, 3, 4, 5, 6, 7, 8. They're all recent ones, 2017, 17, 14, 13. So the accumulating evidence indicates that surgical removal of ovaries may have serious long-term health consequences. It appears that risks are greater for patients who are younger at the time of oophorectomy and did not take estrogen therapy. Suppose you remove at the age of 40, 45, sometimes earlier we used to say anything more than 40, you can remove the ovaries. Then it became 45. Now we are going towards 50 and plus. So younger the patient, more is the health risk if she didn't take estrogen. But if you give estrogen, it's not that it is free from problems. And how long will you give estrogen? Will you give estrogen for 5 years, 10 years? It is not advocated in MHD also. In MS, that is menopausal hormone therapy, or the latest, I took a class some time back, I will take it again, maybe in this lecture series. The lowest possible dose for the minimal possible period, only in the symptomatic women we should give that. So that doesn't mean that you can give estrogens for years together. What is this all-cause mortality? The Nurses' Health Study found that patients who underwent BSO, that is bilateral salpingo-oophorectomy, had a significantly increased risk for death from all cause compared with those who conserved their ovaries. All causes means any cause, any one of these causes, CVD or CKD, and so many other causes. So the retrospective nationwide United Kingdom study, which included 113,000 odd patients, supported the NHS finding as well. NHS means not the NHS the system, but it is Nurses' Health Study. Conservation of at least one ovary in patients ages 35 to 45 who had hysterectomy for benign conditions was associated with a lower all-cause risk. So that's why I'm telling again and again, don't simply remove ovaries because you have opened the abdomen. Now I come to the specific risks, not all-cause risk: cardiovascular disease and stroke. Both BSO at younger age and premature menopause are associated with an increased risk of cardiovascular disease and stroke. Data suggests that estrogen therapy may mitigate adverse cardiovascular effects in this patient population, but estrogen itself can be dangerous to CVS system. And it has been very, very clear, amply clear after the WHO study that estrogen should not be given, or MHT in general should not be given to prevent CVD, to prevent osteoporosis, or to prevent any other problems. It is only to be given, I'm repeating again, for a symptomatic woman, and in the shortest possible dose for the shortest possible duration. Chronic kidney disease. Oophorectomy prior to age 50 may associate it with increased risk of CKD, chronic kidney disease. HRT seemed to mitigate some of this risk in patients less than 45, but again, the HRT itself has got its own risk. Hypothesis: why should there be chronic kidney disease if you remove the ovaries? The hypothesis is that endothelial dysfunction can occur, glomerular sclerosis, and increased glomerular permeability. These are the reasons for CKD. Next, cognitive function and neurologic diseases. Oophorectomy prior to menopause appears to be associated with an increased risk for cognitive impairment of dementia, as well as Parkinsonism. So, as it is, dementia is so risky and dangerous to the patient, as well as Parkinsonism, which usually would come in the later ages in life for anybody. If you remove the ovaries, it can come earlier. Estrogen therapy again may be neuroprotective in these patients, but then I am repeating for the fourth time, estrogen therapy itself can be dangerous. You can't give it on the long-term basis. Depression and anxiety. Early bilateral oophorectomy is associated with an increased risk for developing depression and anxiety. And you see here, median time from oophorectomy to the onset of symptoms of depression or anxiety was approximately 14 years. Even 14 years after your removal of ovaries, there can be problems. So that is exactly why all these problems will come up if you unnecessarily remove the ovaries at the time of hysterectomy for benign condition. Glaucoma. Bilateral oophorectomy before the age of 43 years had a significant increase in open angle glaucoma, and what? It was not ameliorated by patients who took estrogen. All the other problems, what is said, at least if you give estrogen, they can be reduced. But here, even if you give estrogen, glaucoma, once it sets in, it cannot be reversed or it cannot be ameliorated. Sexual dysfunction. Well, if you 40 years, 45 years is not the time when one should stop the sexual activities. So there are women who would request for the sexual activities to be continued. So studies report negative sexual outcomes after oophorectomy in premenopausal patients not treated with hormones. Sexual function outcomes means what? Desire for sexual activity, libido, arousal, satisfaction with sex, and overall sexual outcome. Osteoporosis. Now, this is the biggest silent killer. We all know that. And who is responsible for that? Early withdrawal of estrogen. Menopause is a known risk factor for osteoporosis, as it is. And if we go and remove the ovaries in a younger patient, it will be there with the vengeance. Among patients who were post-menopausal at the time of surgery, there was significant increase in the risk of any osteoporotic fracture. That goes to say, even post-menopausal time, ovaries are secreting estrogen. That's what I told you right in the beginning. In a post-menopausal age. So there also you should not remove the ovaries. That's what is the meaning of this. And as far as likewise, the patients who have premenopausal at the time of surgery had an increased risk of distal forearm and vertebral fractures, but of course not hip fracture. So both post-menopausal removal of ovaries and premenopausal removal of ovaries will push the lady into osteoporosis. And the question is, after all this, whether to die with the ovarian cancer or to die with osteoporosis. And the death with osteoporosis is much more miserable, and it's going to be much more in incidence. I'm going to show the statistics in the end. A hip fracture is, the life becomes so miserable, and there is no quality of life at all. Of course, there is no good quality of life with ovarian cancer as well. But we need to examine the incidences of each one of them. That is the climax of the lecture. Well, I cannot talk unilateral. In a debate, I can talk unilateral, but when I give a lecture like this, I should give a balanced view to the viewers and to the consultants and PGs. There are some benefits with elective oophorectomy. Elective oophorectomy means you are simply removing the ovaries. That's what I mean. What are those benefits? The lifetime risk of ovarian cancer. Now I am talking like a other party who was debating. That is, even though there is no genetic risk of cancer, still there is some benefit of removing the ovary in preventing the lifetime risk of cancer. Now, what is this lifetime risk? I am telling you now, revealing the secret. Just 1.2%. Very, very less. Does this invite oophorectomy? You decide. In patients with BRCA1 and BRCA2 gene mutations, yes, 13 to 46%. Definitely, you should remove the ovaries. There's absolutely no doubt in that. In those with Lynch syndrome, 38%, remove the ovaries. But general population, 1.2%, I am not very sure. Number one. The next slide is going to shock you more. What is that? BSO reduces the risk, but does not eliminate the risk of developing ovarian cancer. You may ask me, when the ovaries are removed, how will the ovarian cancer occur? If the person has the genes to have the ovarian cancer, then the person will develop what is called ovarian-like peritoneal cancer may develop after oophorectomy. So there is no escape. There is no relief. You may think that I have removed the ovaries. But if the person has that strong BRCA1, BRCA2, that person can develop peritoneal cancer. I remember long ago, one of my professors used to say, if the person has got oncogene, you remove, let's say, kidney for kidney cancer. After some time, the person can develop another cancer. Here also, I have seen one of the professors in Sikkim. That person had a cancer in one organ first, and that was removed. And years later, that person has developed now the cancer in the another organ. So that is how it is. So clinical decision making. So with all this kind of evidence, what I have given you, I have to tell you how to make the decision. Otherwise, I'm just leaving you just like that. I don't want to leave people like that. I want to tell some concrete messages. So how do you make the clinical decision? It relies on understanding of genetic risk factors for cancer. The approach to decisions must include comprehensive counseling regarding risks and benefits. Give the decision to the patient. You don't take the patient. This is the new teaching. Not new, not very new. It's been there for long, but at least now we have to understand that you don't take any decision based for the patient. You tell her, look here, This is the risk what you have, 1.2% risk only of developing cancer, which is the general, even if I don't remove ovaries or if I retain the ovaries for general population, 1.2% is the risk. Anybody can have cancer. Okay. Whereas if you have genetic risk factors, then of course, our family history of cancer, and if you can afford, you can do BRCA1, BRCA2 mutations and all those things, then the risk is more. So it makes a case for removal of the ovaries, or if there is a Lynch syndrome. So otherwise, you will suffer these things unnecessarily. CVD risk, KCD risk, dementia, sexual dysfunction, osteoporosis, all this. So when you tell everything clearly to the patient, you have to spend that much of time. After all, you are removing an organ. Just because organ is not useful, can you remove? We have two eyes, can we remove one eye? We can't do that. Shared decision making between clinician and patient. That is very important. Bilateral oophorectomy is associated with small absolute cancer risk reduction for patients who are at an average risk of ovarian or breast cancer. The risk reduction is small. How small it is? Just 1.2% small. Ovarian cancer is not a common disease, and hysterectomy itself provides a small preventive effect. Removal of the fallopian tube may provide added risk reduction. So definitely you remove the tubes, but not ovaries all the time. Some data suggests that association between oophorectomy and decreased risk for breast cancer in patients who are younger than 45 years, but no decrease in breast cancer mortality has been found. So just to prevent on breast cancer, we don't go into a oophorectomy unless there is BRCA1 and BRCA2. So in conclusion, given the current evidence, elective oophorectomy may be associated with an increase in long-term risks. What are the risks? All-cause mortality, cardiovascular disease, particularly in patients who are younger than 45 and perhaps up to 54 years at the time of surgery. What does that mean? At least till the age of 55, don't remove ovaries. In fact, till the age of 65, I would go. Don't remove the ovaries. After 65, maybe there's not much of a benefit. Also, CKD, cognitive impairment, Parkinsonism, psychiatric symptoms, sexual dysfunction, and osteoporosis are additional risks. So in the short term also there is problem. Long-term problems are different, short-term problems are different. What are the short-term problems? Premenopausal patients who undergo bilateral oophorectomy will experience abrupt onset of menopause and will typically have bothersome menopausal symptoms. This abrupt menopause is very, very distressful. Example, hot flashes, sleep disturbance, mood changes, sudden changes. That is very, very risky for her. Conclusion, for patients who have already experienced natural menopause, elective bilateral oophorectomy may be health neutral. Health neutral means there is no benefit, there is no risk. Although ovarian conservation at the time of benign hysterectomy until the age of 65 years, that's what I said in the previous slide, benefits long-term survival, and that the risks and benefits of elective oophorectomy approximate each other after the age of 65. That means after the age of 65, there is no risk, there is no benefit. Risk is general risk. There is absolutely nothing great benefit. That's the meaning of it. So I think we have to be sure that there is no problem in the ovary before we take a decision. If there is no problem in the ovary in any which way, there is no point in removing the ovaries. Suppose there is problem in one of those. That was the question somebody asked me. Yes, if you see one cyst in a particular ovary, remove that ovary. Another ovary at least you can leave behind. This ovary will secrete the natural estrogen, and natural estrogen is any day better than synthetic estrogen. Somebody asked me a question in the morning in the chat box I saw. What about phytoestrogens? Phytoestrogens are not to be given. They are of no use anymore. Right. So this is the final slide that I wanted to show you. Now you decide whether to die of ovarian cancer or osteoporosis or CVD. The ovarian cancer incidence is 1.2%, death is 0.92%. Osteoporosis incidence is 18%, death is 28.3%. And that's a miserable death. and a crawling death. That means for years together, you will be having this fracture and immobility and all those things. And CVD up to 40% incidence, 32% death. And these are all latest figures, American Cancer Society 2022, as far as ovarian cancer is concerned. BMJ opened 2017, and other one is 2015 statistics. So we have to tell our patients this problem. So what to do with the ovaries then? The pendulum has swung towards ovarian conservation in patients under the age of 54. I would put it as 65. So I come back to my first slide, that is primum non nocere. That means first do no harm. Do not remove normal ovaries. Thank you very much. Thank you very much. Tomorrow there is no class. It is a Sunday. Let's enjoy the Sunday.